Thank you. Good afternoon, everyone, and welcome to today's meeting. I am Councillor Abigail Marshall-Cutton, and I am the Chair for Adults, Health and Active Lifestyle. I would like to again welcome everyone and all board members to our new municipal year for 2021 and 2022. I would like to clarify that while this is a meeting that's been webcast live to enable public access, it is not being held as a public meeting in accordance with the Local Government Act of 1972. As such, it is a remote consultative meeting of the Adults, Health and Active Lifestyle Scrutiny Board. The consultative status of today's meeting means that some of the usual formalities will not take place at the start of the meeting. And while it also means that the board will not be in a position to take any formal decisions, today's discussion will still very much help inform the work of the scrutiny board, and where necessary, any proposed actions that do require formal ratification will be referred to the next formal public meeting of the scrutiny board for approval. I would now like to invite members of the scrutiny board, including those who may be in attendance as a substitute member, to introduce themselves in the following alphabetical order. Councillor Anderson.
Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adlan Wharfdale Ward.
Lovely to see you. Thank you. Dr. Beale.
Good afternoon. John Beale, and I chair Health Watch Leeds. I'm a co-opted member of this scrutiny board, and I guess probably, Chair, I need to be re-co-opted in this new session, or not, yeah. Otherwise I have to leave.
That's all right. I'm sure we will. Thank you, Dr. Beale. Councillor Cunningham.
Afternoon, everyone. I'm Councillor Lou Cunningham from Almley Ward.
Thank you, Councillor, and she's also a new member of the board, so thank you for joining us. Councillor Dowson.
Yes, good afternoon, everyone. I'm Councillor Jane Dowson from Chapel Allerton Ward, also a new member of this board. Very exciting.
Thank you very much. We appreciate seeing you. Councillor Gibson.
Good afternoon, everyone. Councillor James Gibson, Crossgates and Wimore Ward.
Thank you, and he's also a new councillor, a new board member, so lovely to see you, James. Thank you.
Sorry, Chair, I have actually been on the board before, so I'm not entirely new, but
okay.
Yeah.
Kind of new. All right, okay. Councillor Harrington.
Good afternoon, Norma Harrington, Wetherby Ward Councillor.
Thank you, Norma, lovely to see you. Councillor Hatbrook.
Hello, Councillor Conrad Hartbrook for the Rothwell Ward, new to this group and new to the council.
Excellent, thank you. You're welcome as well. Councillor Iqbal.
Hi, afternoon, Chair. Sorry, apologies. It was my first meeting with the Metro Mayor, Tracy Brabin. I just had one pre-meeting because we've got the AGM on Friday, so that's why I didn't join the earlier meeting. Councillor Mohammed Iqbal for Hunslet and Riverside Ward.
Thank you very much, Councillor Iqbal. Councillor Kidger.
I am Councillor Wyn Kidger and I represent Morley South. Thank you.
Thank you very much, and also a new member, so you're welcome. Councillor Latty.
Good afternoon, Councillor Graham Latty. I'm from Guiseley and Rawdon Ward.
Thank you very much, Councillor Latty. Good to see you. Councillor Renshaw.
Good afternoon, everybody. Councillor Karen Renshaw from Arlesden Robin Hood Ward, substituting today for Councillor Taylor.
Thank you very much, Councillor. Appreciate that. I would now like to invite the officers supporting today's meeting to also introduce themselves, please.
Good afternoon. I'm Angela Brogden. I'm Principal Scrutiny Advisor to the board.
Thank you, Angela, and thank you for all your hard work. And Harriet.
Thanks, Councillor. Good afternoon, everybody. Harriet Spate, Governance Officer.
Thank you very much. You're also welcome. Thank you, everyone. Could I, at this point, just let you know that just in case I lose any connection, the board has nominated Councillor Latty, who will take over from myself if that happens. So thank you very much, Councillor Latty. Right, we're going straight to the agenda now. Agenda 1, declarations of disclosable pecuniary interest. And I now invite board members to declare any disclosable pecuniary interest. Have we got any? Okay, I take a silence as a no. Thank you very much. Draft minutes of Adults Health and Active Lifestyle Scrutiny Board meeting was taken on the 16th of March 2021 and has been provided for information purposes only. These are to be formally approved at the next formal public meeting. However, if there are any issues stemming from these minutes that members would like to raise at this point, then please do so. Okay, I will also take your silence as you have nothing to raise at this time. I will now call on our Principal Scrutiny Advisor to take us through items 3 to 5.
Thank you, Chair. So in relation to item 3, this report provides guidance to the Scrutiny Board when seeking to appoint co-opted members. So the Scrutiny Board procedure rules within the Constitution outlines the options available to all Scrutiny Boards in relation to appointing co-opted members. The appointment of non-voting co-opted members to represent the voice of patients and service users has been a long-standing approach adopted by this particular Scrutiny Board. And since 2014, the Board has appointed a long-standing non-voting co-opted member representative from Healthwatch Leeds. This organisation again welcomes such arrangements to continue this municipal year, and as such, we've again identified the Chair of Healthwatch Leeds, Dr. John Beale, as its nominated representative. So this approach itself doesn't preclude the appointment of any further non-voting co-opted members, and so the views of board members are being sought today in terms of whether to explore representation from other potential areas too, either as a standing co-opted member or in terms of alternative options available to the board. For example, the board may wish to consider a more ad hoc approach in terms of the appointment of co-opted members linked to a particular scrutiny inquiry where organisations would be able to nominate a representative best suited for that specific purpose. So the views of board members during today's meeting will be used to inform a decision on the appointment of co-opted members at the board's next formal meeting. So I'll pass back to you now, Chair, to discuss this further.
Okay, thank you very much, Angela. For all of us here today, are we all happy to have Dr. Bill remain on the board? If it's a yes, please, could you just give me a thumbs up? Excellent. Dr. Bill, there you go. You're still with us.
Look forward to continuing our discussion.
Fabulous. Right. Angela, are we happy to take any more, or are we okay to just move ahead now?
That's just open for discussion. Obviously, Dr. Beale's appointment will be formally approved at the next public meeting of this board.
Yeah. Okay. Thank you very much.
So are members happy to debate on an ad hoc approach moving forward?
Members, if you're happy, just give us a thumbs up, please, so that we know. Fabulous. Yeah, we're happy, Angela.
Okay, lovely. Thank you. In relation to item 4, this report is for information only. It does set out the terms of reference of the Scrutiny Board as agreed by full council. And to help provide further clarity, Appendix 3 of this report does give an overview of how each of the council's 5 individual scrutiny boards this year have been aligned to officer delegated functions and executive portfolios. Would you like me to move straight on to item 5, Chair?
If you don't mind, thank you.
So in relation to this report, as members are aware, it's this particular scrutiny board that's been assigned to fulfil the council's statutory health scrutiny function, and so this report presents further information and guidance to assist the board in undertaking this specific role. The report does make particular reference to the duty of NHS commissioners and service providers to consult local authorities through its health scrutiny function, where there's any proposal under consideration for a substantial development of a health service or a variation in a provision of such a service in the local authority's area. To assist in this process, a health service developments working group has previously been established. This offers an environment that allows early engagement with the scrutiny board regarding proposed developments or changes to local health services. So it's therefore proposed that similar arrangements are established again for this municipal year. And so draft terms of reference surrounding the health service developments working group are attached to this report for members' consideration. And again, the views of members today will inform the position for approval at the board's next formal meeting. In relation to joint health scrutiny, local authorities are also required to appoint mandatory joint health scrutiny committees where NHS bodies need to consult more than one local authority's health scrutiny function about substantial proposal. So as such, there is already a protocol in place that was established between the 15 upper tier local authorities across Yorkshire and Humber region for establishing a joint health scrutiny committee. But I would like to draw particular attention to the existing West Yorkshire Joint Health Scrutiny Committee that was established back in November 2015 as a discretionary committee, often referred to as the JOSC. So the JOSC primarily maintains oversight for developing West Yorkshire and Harrogate Health and Care Partnership across a range of programme areas and other matters. More recently, the JOSC has been working with the partnership to consider the potential impact of new legislative proposals that's linked to the forthcoming Health and Care Bill, and we'll be maintaining an overview of this as proposals for the new integrated care system for West Yorkshire continue to be developed, which is also includes a key focus around what the potential future the role of scrutiny will be as part of that system too. So while this scrutiny board will be kept up to date on the work undertaken by JOSC, it doesn't preclude it from undertaking its own work on key matters such as the forthcoming legislative changes, should it wish to do so. The membership of the JOSC consists of 2 members of the relevant Health Scrutiny Committee within each constituent local authority. So Leeds' representatives have been the chair and another member of the scrutiny board. So members are therefore asked to consider the board's representatives on JOSC for this municipal year, while also recognising that such arrangements may well be subject to further review linked to the, as I say, the legislative proposals in the forthcoming Health and Care Bill. So the views of members at today's meeting regarding representation on JOSC will inform the position for approval at the board's next formal meeting. So again, I'll pass back to you, Chair, for discussion on those 2 particular areas. Thank you.
Okay, thank you very much, Angela. So I take it the chair will be myself to attend JOSC, which I did in the last municipal year. So we need 1 more person from the board. Is that correct?
Yes, Chair, that's correct.
And we had Councillor Latty from the last year as well. So Councillor Latty, is that something you're happy to do again, or would we like to nominate someone else?
I would be happy if you wanted me to do it.
Okay, board members, are we happy to have Councillor Latty and myself from the JOSC board? Is that thumbs up? Sorry, you see, with online meetings, if you don't show me the hands up or the eyes, it's very difficult to know what you're thinking. So a thumbs up will always be great for me to know that we're all together. So thank you very much. So yeah, Councillor Latty and myself are delighted to serve again for another year on the JOSC board. Angela.
Thank you, Chair. And then it's just confirmation that we're happy to continue with the Health Service Developments Working Group for this municipal year.
Yes. Are we all? Thumbs up again if we are. Fabulous. Thank you.
Thank you,
Yeah,
Chair.
it's a yes from all of us, Angela.
Thank you, Chair.
Okay, excellent. Right, so moving on to the reports, we're going to go into item 6, which is sources of work for the scrutiny board. This report provides information and guidance on potential sources of work and areas of priority within the board's term of reference. Members are asked to consider this information when discussing potential areas of scrutiny work for the forthcoming municipal year. It has been custom for relevant directors and executive board members to share their views and to contribute to the board's discussions surrounding potential areas of scrutiny board. Given that this board does include the council's statutory health scrutiny function, an invitation was also extended to senior representatives of local NHS organizations to provide an opportunity for them to also share their views and contribute to the board's discussion. I will now invite all participants to kindly introduce themselves, and I will start with Councillor Venner.
Thank you, Chair. My name's Councillor Fiona Venner. I represent Kirkstall in West Leeds, and I'm the Executive Board Member for Adults and Children's Social Care, Early Years and Health Partnerships. Thank you.
Excellent. Thank you very much, Councillor Venner. Councillor Arif.
Thank you, Chair. I'm Councillor Salma Arif. I represent Gibson and Hare Hills. I'm also the Executive Member for Public Health and Active Lifestyles. Thank you.
Excellent. Thank you, Councillor Arif. Kath Ruff there.
Good afternoon. I'm Kath Ruff. I'm Director for Adults and Health.
Thank you, Kath. Lovely to see you. Victoria Eaton.
Good afternoon, everyone. I'm Victoria Eaton. I'm the Director of Public Health at Leeds City Council.
Thank you, Victoria. Good to see you. Phil Evans.
Hi, everyone. I'm Phil Evans. I'm the Chief Officer Operations and Active Leeds with responsibility for Active Leeds.
Thank you. Good to see you. Steve Baker.
Good afternoon, everyone. I'm Stephen Baker. I'm the Business Manager for Active Leeds.
Good to see you. Tim Riley. Tim not here?
Sorry,
All right.
I didn't hear that. Hi, Tim Riley, Chief Executive Leeds CCG.
Thank you. Good to see you. Sarah Monroe. Have we got Sarah here? All right, I'll move to Sam Prince.
Hi, I'm Sam Prince. I'm Director of Operations at Leeds Community Healthcare, and I'm also the Senior Responsible Officer for the vaccination programme.
Thank you, Sam. Good to see you. Rob Newton.
Hi everyone, I'm Rob Newton, Associate Director of Policy and Partnerships at Leeds Teaching Hospitals, and I'm here today for Julian Hart, who's on leave this week.
Excellent. Thank you, and you're welcome. Right, I will now invite our executive members to firstly provide an overview of their key priorities for the forthcoming year and to share their views on where scrutiny could potentially add value. So I will pass now to Councillor Venner, and you all have got 5 minutes each, if you don't mind.
Okay, thank you. So we've also just done this same process in children's scrutiny last week. And one of the areas that that board is going to get regular reporting on, and my recommendation would be that you do too, is the impact of COVID, which obviously is the biggest challenge for health and social care moving forward. I think obviously from a social care perspective, that's within the context of what seems to be very broadly recognised as social care being inadequately funded nationally. At the same time, you've got increased demand on services, and the fallout of COVID it is starting to be seen now in terms of increased demand, in particular parts of the system like at the front door, and a huge increase in demands for home care. So my suggestion would be that we do a regular report. We've done it quarterly on children's scrutiny right the way through the pandemic, in terms of a report on of the impact of COVID on different parts of the Children's Directorate. So my suggestion would be that you get a regular, i.e. quarterly or 6 monthly report on the ongoing impact of COVID. You also, I think, traditionally have had a regular report on the quality of registered providers, which I would suggest continues. And the other, of course, really big thing happening in the health system is the development of the ICS. And so it would make sense that you also get a regular update on what's happening with the development of the integrated care system. So those would be my suggestions in terms of things that are scheduled in to be reported on regularly. In terms of areas you might want to look at, Kath is currently undertaking something called the Listening Project, which is about increasing access to social care for people from BAME communities. And this is straying into Councillor Arif's portfolio, but tackling health inequalities is really clearly a major priority for the whole city. And one thing you might want to consider, which could be jointly with children's actually, is whether you look at the Marmot Building Back Fairer report and how we would judge ourselves against the recommendations on that. Marmot is very child-centred and really recognises the value of things like early years. That's why I was suggesting if you did want to look at Marmot and how we do build back fairer, it might make sense to do that jointly with children's. Another area, I think this might have been looked at previously, but in this scrutiny board before I was the exec board member, but transitions is a priority for the city at the moment. It's a priority in the Future in Mind strategy, which is the Children and Young People's Mental Health and Wellbeing strategy, and it's also a priority in the All Age Mental Health strategy. in that context, it's looking primarily at transitions between CAMHS and adult mental health services, which I think this board has looked at previously. But I've become aware that it's equally challenging for parents of children with disabilities and additional needs transitioning from children's to adult services. So there is quite a lot of work happening anyway in the city around transitions. And finally, I mean, this could be very much linked to the impact of COVID. There's the issues around the backlogs in the NHS in terms of treatment and whether you wanted to look at that and the impact of, I mean, I know Health Watch have recently done a survey about the impact on individuals of waiting for appointments and waiting for care and treatment. So I don't know if you want to consider that as well. So those are my suggestions in terms of areas I'd recommend you get regular reports on, and a couple of areas you might want to look at in more depth. Okay, thank you, Chair.
Thank you very much, Councillor Venner. Has anyone got any questions for Councillor Venner? Everyone is happy with what you would like us to take forward, Councillor Venner. Seems to be no questions. I don't know, we had, there was a councillor who had his hands up earlier on and I think I missed him. Is that correct? Councillor Jenkins, did you have your hands up earlier? No? Okay, Councillor Anderson. Councillor Anderson?
Yeah, sorry, Chair, I'm having trouble trying to unmute. I keep pressing the button and nothing happens.
That's okay.
I just wanted to see, Councillor Venner sent an email to all councillors this morning about a review of charging policies within adult social care. And I just wondered why that had not come to scrutiny in advance, because we've not seen anything about that. And I wondered whether that we should really might have scrutinised the consultation process, or if not the consultation process, what happens after that and the outcomes of the policy, should it be implemented following the consultation. Thank you.
Thank you, Councillor Anderson. Councillor Venner, would you like to reply to that?
Yes, this is a consultation that we're undertaking in the context of the massive financial challenges the council is under around charging around two aspects of adult social care. So one is a consultation around removing the maximum assessed charge. So at the moment, I mean, most authorities do have a cap, don't have a cap, and we have capped the amount that people pay weekly for their care, regardless of their income. So one of the areas that we're consulting on is whether we remove that cap, so people will be financially assessed to see what they could afford. And the other charge is really correcting a kind of anomaly, really, where at the moment, if we're directly providing care to people as opposed to them having direct payments, if people have two carers, we're actually only charging them for one. So that's the other thing we're consulting on. And again, for the people that would affect, that would be financially assessed. The consultation is just starting this week and it's for 2 months until August. And after that, a report would go to executive boards with the outcome of that consultation. I don't know, Kath, if there was any, I don't know if there was a plan at any point to bring that to scrutiny.
It's not scheduled to come to scrutiny, but if scrutiny board members wanted to comment on the process, we would be happy to receive any feedback if there's things we could do to enhance the consultation process we're going through. And obviously, when it goes to executive board and a decision is made, there is the ability to call it in as well. If it would be helpful, Chair, I can write out to scrutiny board members setting out the consultation process that we are planning to undertake.
Sorry,
go on, sorry, Councillor Venner.
No, sorry, I didn't mean to interrupt you. The documents I've sent out, they are very comprehensive in terms of there's a covering email from me, this has gone to all members today, and then there's a leaflet that is what will go to people who are in receipt of services, which is really clear. It's deliberately written to be obviously understandable for people who've got care needs. And there are a number of different ways people can contribute to the consultation, and we've involved different organisations like AdvaNet, for example, to directly support people who may be affected. It affects a relatively limited number of people in terms of the people that currently have 2 carers but are only charged for 1, and people, and people who are paying the up to the cap, but the information is going out to all people in receipt of non-residential social care. So it's quite a wide consultation to get a lot of different people's views, even though it affects a relatively small number of people.
Okay, thank you very much, Councillor Venner. Dr. Beale.
Thank you, Chair. Councillor Venner has given us a very important list, and I certainly wouldn't dissent from any of the things on our list. It does mean we're going to have a very busy year, but I think they are all important issues which do need to be properly looked at. I'm particularly interested in building back fairer, and I want to raise one issue on that in the next item on the agenda anyhow. It's slightly more biased towards health service than it is to social care. And therefore, I'm sure that we would want an early look at the impact of COVID, to be looking at the impact of COVID on social care, both in care homes and in home care as well. So yeah, it's a busy programme, but it's an important programme. And just to say that I'd be very happy to share any information, for instance, that Health Watch has on the backlog of patients and the effect on personal health.
Definitely, Dr. Bill, that's very helpful. I'll also be interested in the effects of long COVID as well, whilst you're doing some of the COVID work. So that will be very helpful. So thank you very much. I'll bring in Councillor Cunningham, please.
Thanks, Chair. Thank you, Councillor Venner. Yes, within the areas of the COVID impact and health inequalities, the other group that I would like to add is people with learning disabilities into that, and also separate from that, and more both the impacts of COVID and more generally dental health care inequalities around the city.
Thank you very much. Councillor Venner, do you want to reply to that?
Yeah, sorry, I was just trying to unmute. Yes, absolutely, I agree with the points that have been made. In terms of the impact of COVID, one of the things that we've become aware of, this is as much as a ward councillor as in my executive board role, is neighbourhood networks and other groups working with older people, like Leeds Older People's Forum, are raising huge concerns about a really large number of older people who've lost a huge amount of mobility and confidence in the last 15 months because they've been at home all the time. So, you know, people who were doing their own shopping once a week, who were getting that done, you know, by volunteers or by friends or neighbours. And as a result of needing to stay at home because of the pandemic, have just lost a huge amount of confidence and mobility. And that feels as much of a tsunami as the tsunami in mental health in adolescence. It feels like, in terms of my portfolio, those are my really big concerns in terms of the fallout of the pandemic at either end of the age range. And I think that needs, if we were looking at the impact of COVID, I think in terms of the impact on older people, obviously the impact on care homes is very much in the news and people are aware of that. But I think there's a kind of hidden impact, which is, you know, literally thousands of older people who have lost a lot of mobility and confidence. A really heartbreaking thing one of our neighbourhood networks in Kirkstall said was that last summer, when there was a window and they could bring people back together, when they brought groups of older people back together, they couldn't talk to each other. They'd literally lost the art of conversation, which seems really heartbreaking, and staff had to be much more interventionist in keeping conversations going because people had sort of almost got settled in isolation and used to not talking to anyone. So I think in terms of both physical health, mobility, isolation, confidence, you know, the world looks really different. Going to the supermarket now looks really different. And I think that's a really concerning impact of COVID that we would want to cover if we were doing reporting back to you on the impact of COVID on the city. Thank you.
Thank you very much, Councillor Venner. Okay, Councillor Gibson. And then we will move on to Councillor Arif after this.
Thank you, Chair. Yeah, I'd just like to reiterate what Councillor Cunningham said around looking at the impact of COVID on health inequalities for people with learning disabilities, and just add on to that people with autism as well as learning disabilities. So,
thank you very much. Okay, we shall now move on to Councillor Arif.
Thank you, Chair. So as you'll know, I took on public health back in February, and the key priority really was to ensure that the vaccine reached our communities. We know that the COVID pandemic has impacted communities who are our most vulnerable. So from my perspective, it was really important that the COVID vaccine got to our communities and into the heart of our communities. And actually just looking back and reflecting back over the last few months, some of the success stories, I was driving past Bilal Centre, and even today there was, there was queues, and that goes to show that there's a lot of work that normally parts of those communities that it's difficult to get into, we managed to really get into. I think for me that was sort of the key. The Bilal Centre has been a massive success. The roving buses, again, being data driven, it was ensuring that we followed the data. We went where our communities, we knew the uptake wasn't great. The women's only vaccine was a resounding success, and it has been a team effort. Obviously there's still quite a bit of work to do, but as we come out of the COVID pandemic and into the recovery phase of things, and absolutely, as Councillor Venner said and others have said, in relation to building back fairer, we've got to, and I've had conversations about this, we've got to go into the hearts of our communities and be accessible. I think that's something that I will certainly be focusing on going forward. As you'll be aware, I'm now also the Cabinet Member for Active Lifestyles. Looking at some data early this morning, the wellbeing centres, the usage in inner cities are very, very low as opposed to the more affluent areas, and how we make sure we build that confidence in our communities to be able to be active. The pandemic has obviously, and I'm sure this will be mentioned later on, inactivity levels have gone down within the pandemic, and that's something we need to work on. But fundamentally, going forward, it's for me, it's really important that any work we do in terms of health inequalities, we take our communities with us and we work with them. There's various different barriers in our communities, and it's important that we learn from the lessons that we've learned from the COVID vaccine in terms of going to our communities. So there's a lot to do, and it will be a challenging year, as Dr. Beale has said. But I'm excited, and I think for me this is a challenge, but also an opportunity as well. Thank you.
Thank you very much, Councillor Arif. Now call on board members. Have you got any question for Councillor Arif? Okay, excellent. We're just going to move on swiftly now. Thank you very much for that. I would now call on officers to also tell us about, give us an overview about their portfolios as well. And could I now call on Kath Ruff, Director for Adults and Health, please. About priorities for this municipal year, please.
Priorities for the suggestions for scrutiny board, or just what might, yes. Well, I think Councillor Venner covered a lot of them. The extra things I would suggest is looking again at the role local care partnerships play as a real building block in the city for health and care to come together, and wider local government services. In terms of our vision for the city for health and wellbeing, they're absolutely key. The other thing I would possibly have a look at as we are refreshing the Better Life strategy, which is the council strategy for people with care and support needs, increasingly getting the right roof over somebody's head is an equally important part of the practical care that goes into somebody's dwelling. And if we look at our demography and our ageing population, do we have the right housing strategy in the city, or housing with care strategy? And increasingly, what are the right models of support in terms of housing for working age adults? So we're very comfortable and confident with extra care, but we don't do that for working age adults with very valid reasons. But then what should be the right models, and to bring some sort of thinking and get some challenge back from Scrutiny Board around that. Otherwise, I think but maybe a bit later on in the year, you might want to have a look at the liberty protection safeguards that will be introduced as legislation is changing, and how that is enacted and the implications of that. So I think that those would be my 3 suggestions in addition to what Councillor Venner has suggested.
Excellent. Thank you very much. Any of the board members? Yeah, all right. Councillor Gibson, I've seen your hands up. Councillor Gibson, was that an old hand?
Sorry, it's on mute. Yeah, thank you, Chair. I just wanted to say thank you for Kath for raising LPS and changeover from community doles. I just wondered whether or not it would be the place of this board to have a look at the impact of that change of legislation on our workforce and workloads, and how it will be practically implemented.
Thank you very much. Kath, do you want to reply to that, or it's been noted?
Yes, I'd be supportive of that.
Okay. Excellent. Thank you very much. I will now move on to Victoria Eaton.
Thank you, Councillor. Sorry, I was just silencing my phone. I really echo the comments that have been made so far by both Councillor Venner and Councillor Arif and Kath. I would just maybe add a couple of additional comments to that from my perspective. I guess to mirror the suggestion from Councillor Venner around looking into the development of the integrated care system and what it means for Leeds. We're also going through a very significant period of reform to public health services. So Public Health England nationally and locally, and other parts of the public health system are already changing pretty fundamentally. So I think it will be useful to have scrutiny and oversight of that and how it impacts on us as a Leeds system. So I'd certainly highlight that to the Scrutiny Board. The second area relates really to the conversation about impact on health inequalities. And I know this is huge, and there's various different groups of people we might want to look at around specific impact. I guess it's helpful to make the point that we're often talking about impact of COVID in the past tense, and we know that we're very much still in the present tense with COVID, certainly this week, and even beyond the now magical date of the 19th of July, we still will be living with COVID. So I think it feels important that as a Scrutiny Board, there are ongoing conversations around how we continue to respond and manage kind of life with the virus and the impact on health outcomes and health inequalities, because we know that it won't be in the past tense for a very long time, and also how that relates to other infectious diseases, how it links in with things like the flu programme, etc. So there's a kind of bundle of stuff there. And I'd echo Dr. Beale's comments and others about the opportunity to look at the work of Michael Marmot to provide a framework for understanding how we would move forward as a city there. And then the last area is slightly different. And it partly brings together the changes in the NHS with our public health responsibilities as a council. And often some of the areas that are very specialised, but often quite overlooked are the the clinical services that as a council we commission for the people of Leeds, which include our sexual health services, both in the hospital, community trust and primary care. Other services, health checks and other services in primary care, GP practices, and also the health visitor school nurse 0 to 19 service, which are critical NHS services, but they are commissioned by ourselves as a public health service of the council. So just to be it would feel useful to have an interest in how those services can be further developed, given all the changes we have in the system, to ensure that we're providing the best services for the people of Leeds. So they would be my kind of 3 additions to the conversation. Thank you.
Thank you very much, Victoria. Board members, anyone got questions for Victoria? Yes, Councillor Dowson.
Yes, you in the last sort of little bit you did, Victoria, you mentioned health checks, and in the pre-meet we did discuss the reports that had come through with regard to access post-COVID or the new normal, as they say, to GPs and to services in hospitals. There are huge waiting lists. There are lots of people who haven't been seen, who potentially should have been seen by their GP. And on page 134 of the thing, it actually gives a doom-laden scenario of premature death in future years through lack of delivery by GP practices, especially down to the health checks. So I think that with regard to COVID, access to services, be it dental services and so on, the inequalities of opportunity to visit your GPs in different communities, etc. I think that's maybe something we can look at. It's very timely to look at that now, as we've got another 4 weeks before we get to the next phase, but it's something that we do need to look at as a city.
Thank you. Sorry, thank you very much, Councillor Dowson. Victoria, would you like to come back on that, please?
Yes, thank you, Councillor. I don't know if you want me to pick up on the specific issue of health checks now, or to leave that till the later report when they're included in the paper.
No, I think I'm quite happy for you to leave it, Victoria. It's just you were talking about that in your report, and it is something that I personally would like to look at, how we're going to re-engage with those services as part of our workload going forward. So it just seems like an opportune moment to mention it.
Yes, thank you, Councillor Dowson. I support those comments and happy to pick up in the next conversation.
Thank you very much. Any other questions? Okay, I will now call on Phil Evans.
Thank you, Chair. I think the key priority, which will be of interest for the Scrutiny Board this year for Active Leeds, is really about how we take forward the work on making physical activity a key element to a post-COVID world, and accepting Victoria's point completely that it isn't a post-COVID world, but it's a continuing COVID world. And I think it's about us recognising the opportunities that exist there on a systems basis to try to make sure that as many agencies and partners across the city are doing all they can do to get as many people as possible across the city, whether they be residents, visitors, or indeed businesses, and what they're doing in terms of their employee offer, are encouraging people in the city to remain as active as they possibly can. As Councillor Arif has pointed out, there's a differential impact in that, and we do recognise there's a real need to make sure that quite a lot of effort and a lot of focus is on those areas with the greatest inequalities, and that's probably what I'd suggest was. Oh, sorry about that. I seem to turn my video off halfway through there, and that's probably what I'd suggest was the key priority for Active Leeds in relation to the board.
Okay, thank you very much, Phil. Have we got any questions for Phil Evans? Okay, we will now move on to Steve Baker.
Thank you, Chair. I think Phil and Councillor Arif have kind of covered the main priorities really for Active Leeds that kind of need to consider. Again, it's clear that the inequalities in terms of physical activity, and as we kind of talk on the performance report in the next part, is we really do have to kind of address those kind of inequalities that have existed over this COVID time, and how we kind of move forward on that is going to be really important, that we kind of start to address some of those. But again, as Phil kind of outlined, it's how we do that across Leeds with all the stakeholders and partners that we really need to kind of get on board through that process as well. Thank you, Chair.
Okay, thank you very much. We will now move on to our NHS guest, Tim Riley, Chief Executive, NHS Leeds Clinical Practitioner Group.
Thank you. A lot of what I was going to say has already been covered, which is good, because that sounds like we've joined up system. But I suppose what I'll do is I'll just set out a few of our priorities, and then perhaps make suggestions as we go through around where within that there might be specific focuses from the scrutiny committee and point of view. So I suppose I think it's probably worth saying right at the beginning, there's not a huge amount of major service reform planned, if any, partly because the NHS is running on a very short-term set of budgets. So I know the budget till the end of September. I have no idea what my budget is for the second half of the year, which makes that kind of forward planning almost impossible. There are some financial challenges in the system, but we're confident we'll get through certainly the first 6 months. As I say, no idea about the second 6 months. So there's no need for sort of service reduction type changes, but equally there is no confidence to make major service changes in the opposite direction. So at the moment we're in a little bit of a stasis really. Having said that, we've also got a huge amount going on and a huge amount of pressure. So it's probably in some ways helpful that we can focus on the here and now and not plan to turn the world upside down too much. So in terms of the sort of key areas of focus, we've mentioned the legislative change, both the creation of ICSs. I suppose what I've not really heard, and I think it's really important, is understanding, particular for the bigger ICSs like West Yorkshire, there's also this concept of the ICP, the Integrated Care Partnership, which is a place, Leeds, Wakefield, Bradford, and so on, and making sure that's developed in a sufficient way to take delegated responsibility from the ICS. And I certainly think it would be worthwhile having conversations through the year to test some of the thinking around that. Just as sort of illustrative, I guess it's worth bearing in mind that with West Yorkshire, once it receives the sort of funding through from the NHS, will probably be passing somewhere between 1.5 and 2 billion pounds a year through to Leeds. And normally that would have come, a lot of that would have come, 1.4 billion would have come directly through to CCG, which won't be here next year. So we need to make sure we've got the right structures, the right degree of transparency and independence and scrutiny of that processes and about how that money is utilised and allocated. So that's certainly one area that's quite large on our agenda. I think much of the local change within that legislation is really helpful. The timing of it is not, but that is where we are at the moment. In terms of services, a lot of this is really about COVID. The pressure on same-day services in the system is huge. I'm sure I may get some questions around primary care, which I'm very happy to discuss. But I would think broader than just whether it's GPs or A&E front door. It's really a same-day response. So how is the system responding to people who want a service and interaction in terms of care on that day? And that's certainly how we're tending to refer to it. I think looking at it in the round is probably a more constructive way. So that's one suggestion. Another thing that's already been mentioned is around the sort of planned care and the backlogs in primary care around things like screening, but also backlogs clearly in elective surgery. Those are going to test us probably certainly the latter for a few years to come. Within both those, I do wonder and would appreciate probably a focus through a health inequality lens. Are these challenges that we're facing in terms of immediate demand and backlog worsening or are they worsening our health inequalities, and in what way? And what are we doing as a service to adjust as best we can to that? The third area really to mention is around mental health. Just as everywhere else is seeing increased demands, we're seeing that there. Really pleased about the suggestion around transitions, one of the pieces of work that we've set up to test the value of working in more integrated ways at a sort of structural level. is a set of programs, development projects, which with sort of intensive oversight of them. And one of those is the transitions between CAMS and adult mental health services. So I think that is absolutely an area where we might want to focus. There are other areas we're seeing around mental health and demand, particularly in crisis. So again, that same day aspect, but also things like eating disorders. So there's some real challenges in those areas as well, which you might want to take a look at. Two other areas possibly. Kath's already mentioned local care partnerships and the role they're playing. They've carried on running and working throughout this pandemic really effectively in many ways, contributing both to our direct pandemic response, but also I think building a sort of strong basis for future development. So that's something we wouldn't want to lose sight of. And then finally, on this really, we've just had another announcement about more funding coming in for long COVID. So these are people who have particular complications having had COVID. We've got a sort of world, I think almost I would say a world beating service in Leeds, at least that's what we'd like to think. But that's going to need to be developed and maintained over a number of years at the very least. And is something that we would be focused on in terms of its development over this next 12 months. So those are sort of some of the sort of quick cover of the highlights. I think the dental inequalities one is really interesting because dental funding is controlled outside of Leeds at the moment. Many of you may well have raised through letters to me what's happening with dental services, and quite often the answer is I'm trying to find out from NHS England because I'm not quite sure. There are conversations going on at West Yorkshire. If I was to say anything, I might suggest that might be something the JOSC might want to look at, because dental services tend to be commissioned at a broader level than just in Leeds. And certainly at the moment, as a CCG, we have no commissioning function for and responsibility directly for dental services, but I know they are a considerable problem. I don't think I'll say more than that. I'm very happy to just give you some facts and figures around the situation in primary care, which may prove useful. But I always would rather just give you those highlights of where our priorities are and some hints about what you might want to be looking at this year.
Thank you very much, Tim. And priorities sound very, very spot on from our previous discussion as well. And obviously, for me, long COVID, from what we can see right now, is something that's coming through with lots of reports and lots of people not knowing exactly why that is. So good research and where we are with that will be very, very, very helpful. So I am happy to take questions as well from what Tim has just outlined to us. Dr. Beale.
Thank you, Chair. New members of this board may not know my background. I'm retired consultant in dental public health for the Yorkshire and Humber region. But now, as I said earlier, I chair Health Watch Leeds, and the 5 Health Watch organisations in West Yorkshire took a paper on access to dental care to a group under the ICP emerging structure called SOAG, and I can never remember quite what it stands for. I'm sure Tim Riley would put me right there. But I did suggest at that meeting that we set up a working group to look at access to dental care across West Yorkshire and Harrogate. And that group has now been formed. I am a member of it. So I'm very happy to keep members scrutiny board up to date with what we're finding. As Tim says, at the moment, dental services are commissioned by NHS England on a regional basis, although it's a national contract. And some of the changes which I believe are desperately needed need to be made at a national level. Now, MPs might be of help in that, but also Rob Webster, who is the chief exec of the West Yorkshire and Harrogate ICS, I know is in constant contact with the ministers. So if we can persuade him that there are things which ought to be done centrally to help us in West Yorkshire and the rest of the country, then I think that may be a way forward.
Thank you very much. Councillor Dowson.
Yes, Chair. It's on a completely different tack, and being a new member, I'm not even sure whether it falls under the remit of this this group. Sorry, and that is hospital pharmacy services. You know, you get discharged at 10, or your doctor tells you can leave at 10 o'clock in the morning, and you're still waiting at 6 o'clock for your tablets to turn up in your bed. Often, well, you are at the moment, because I understand that the suite where you would normally sit is closed, but you know, the pharmacy service does seem to cause a bit of a backlog in discharging patients, and I'm just wondering whether that is something, and obviously it seems quite minor when we're talking about such huge issues, but it is something potentially in hospitals that could make a difference. Every half day or day wasted when a bed could be available might make all the difference to somebody.
Absolutely. Thank you very much for that. Would you like to come back on that? Can't hear you, sorry, you're muted.
Yeah, sorry, I was struggling to hear. Rob Newton may want to comment as well. I think really supportive of the dental piece, absolutely, that's where it should be sat. Interestingly, they came back to all the places and asked for contributions from the places around the dental piece, as if we did have those people doing that work, but nevertheless it's the right thing that's happening, and I'm really pleased that it's there. In terms of the hospital pharmacy services, we're constantly reviewing, looking at and considering in a collective way the flow through the hospital and that whole set of issues around discharge. And what I think we would all say collectively is two things. One, every part of the system knows it could and should continue on an improvement journey. And secondly, every single part of the system and some of the delays and so on are very, very interconnected. And so to talk about one aspect in isolation doesn't really solve it, sometimes creates additional problems further around the system. So there is a group, Sam as well may well want to talk about this because she's involved if need be, on the piece around discharge and flow. We tend to refer to it as flow because it's more than just the moment of discharge, it's the whole setting in terms of the community as well as what's happening in the hospital, and the connections between the two. But yes, we're aware of a number of multiple issues that will need to be continually worked on, but I would urge to do it in a collective way rather than pick out one issue from many.
Okay, thank you very much.
If I could just come back on that, Chair, because as many of you will know, I was in hospital myself in January undergoing cancer surgery, and 3 of us were in the same ward. And all 3 of us, it was a ward of 6 beds. 3 of us were in a similar position of having to wait an awfully long time. And at a time when you just know people are desperate to have surgery and get into hospital, that seemed to be the one thing that we could put our hands up and say it's happened to us, because we were all waiting to get our meds to actually leave. And the more people I talk to, the more that is mentioned again and again. So I can quite understand Tim saying, yes, it's a matter of flow, and often with older people, you've got to get care in place and all sorts of things. And maybe it isn't for this particular scrutiny board to look at this particular time. But I've got to tell you, Tim, it is something that is very concerning amongst members of the public here in Leeds.
I agree. Sam, Tim did say you might have some information on the discharge. Is that something you can shed any light on for us, please?
Well, I think Rob also wants to come in, but what I would say is that as system leaders, we're looking at all the issues associated with flow, as Tim says, and pharmacy is definitely on that list of things that we're considering.
Okay, excellent. Thank you very much. Rob, over to you.
I guess thinking of discharge just specifically within the hospital, timeliness of medication is big on our list, amongst other things, but it's an important issue. It's and there's a lot of focus on it for us as an organisation, on 2 parts really. Firstly, in how we use our quality improvement method. So there's a lot of improvement we're continually trying to improve our processes. And then secondly, it's just from a technological point of view, there's been quite a lot of upgrades in terms of the automation of some of our pharmacy services internally. to make sure that medications are provided in a more timely way. So yeah, I'd echo both things, both that it's an important thing, and it does cause backlogs within the trust, and it's an important thing within the wider discharge and flow issues that we have across the system.
Okay, excellent. Thank you very much. As long as you all know that these are issues that we would like to discuss as the year goes on, then I'm happy with further information as we go along with the year. So I would now call on Sarah Monroe. Sarah, are you here? Now, you were not here when we did the introduction, so could you kindly introduce yourself, and then if you can let us know.
Yeah, thank you. Thank you.
The scrutiny board.
Apologies, Chair, and I do have to go shortly. So I'm Sarah, I'm the Chief Exec at Leeds and York Partnership Trust, and the reason I've got to go is I'm due to go direct into a meeting about the ongoing developments of Red Kite View. So later this year, we will be opening at the St Mary's Hospital site in Armley a brand new 22-bedded child and adolescent inpatient unit, which will be 16 general adolescent beds and 6 psychiatric intensive care beds. So a big step forward in terms of capacity for West Yorkshire, but with all things considered, and especially the COVID impact, and I'm sure Sam will be able to share more around the pressures that are being seen in community CAMHS, demand is certainly on the increase. Similar themes in terms of the impact from a mental health and LD point of view that others have shared, the COVID impact in terms of increased demand, backlog in some of our diagnostic services, and the challenge within our inpatient environments of meeting COVID requirements for cohorting, isolation and management of an outbreak means that we do anticipate an ongoing increased likelihood of some people needing to go out of area for inpatient stay, simply because we won't have sufficient inpatient capacity within Leeds, and we're not on our own in that situation. So that's another piece of work for us. A couple of other areas I'll share. So as part of us changing our model of provision, especially within our community-based services, and using more digital and virtual means of offering alternatives, we do a significant amount still face-to-face because it's right and proper to do so. But what's really important for us is the whole issue around digital poverty and inclusion, and working with partners to make sure that we don't create any unintended access issues. On the theme of access, we continue to be part of, again, with many colleagues sat around this table, what's called the Synergy Collaborative. So those of you that aren't aware of that, that's work that we've been doing with public health, with the CCG, with primary care and many other colleagues on how do we do systemic work to reduce the overrepresentation in particular of people from Afro-Caribbean backgrounds in the more secure end of mental health provision. But that goes hand in hand with improving the access much earlier on, both for children and young people and for adults. And our commission has funded some dedicated posts, and that's work that's been overseen and reports through to the Health and Wellbeing Board periodically as well, because there's a whole system sign up and commitment from an inequalities point of view to make some real change. And then the final area I'll just reference is we have continued to see go from strength to strength our approach to strategic workforce change in Leeds, with a delivery arm through the Health and Care Academy. Again, all partners are involved, including BCS, independent care home sector colleagues, and that is something that we see as part of our longer term strategy of having a different approach, whether it's around wellbeing at the moment. The Academy really led on the work that we did to recruit into vaccination hubs, not just for us, but across West Yorkshire as well, and lots of different opportunities from that. And we're going to engage with all of our workforce over the coming months on what we're calling a hearts and minds piece, to find those stories of where change is really happening on the ground, making a difference to our citizens, because our teams have been enabled to cut across organisational boundaries and blockages, get those stories and those lessons learned, and that will inform some of the work that Tim was referring to on how do we really fix in the best ways of working in an integrated way, and learn the lessons of where it's gone well and where it's not gone so well. So I'll pause there in case there's any questions. Then apologies if once I've answered the questions, Chair, I will need to leave to go to this next meeting.
That's okay, Sarah. Thank you very much. Can I call on Sam to just buttress and add more to what Sarah has said? And I believe, Sam, you're still going to be here anyway to help take some questions if Sarah's got to leave. Is that right? You're muted.
Yes, I'll do my best to answer Sarah's questions, but we might need to go back to her. So I think one of the things that I was going to say as part of my priorities was just to note just the surge that we've had in referrals for both the CAMS service and the Leeds Mental Wellbeing service, and how we prepare ourselves to make sure that we can meet that need. So it echoes what Sarah said, really.
Now over to the board. Have we got any questions for Sarah and Sam? No questions? Oh, wow. Fantastic. Right, Sarah, you're okay to go. Thank you very much. You take care. Thank you. Right, I believe, Rob, over to you now.
Right, so I'll go through a few things that are important to us. I'll pick out a few things that may be of interest to scrutiny, but I guess I'll leave that to you as well. So I'll go through a few main areas, and apologies if some of this is echoing what people have said, but I guess like Tim said, that's also encouraging. So so the first one, which is at the forefront of our mind at the moment, is the management of our non-elective pressures, same day services. Previously we've brought things to scrutiny on our winter planning. This year we're referring to it just as seasonal planning, because it's not, a once in a year pressure. We're experiencing significant pressures at the moment, and so the understanding of people's access to same day primary care, unplanned care, and how they access urgent and emergency services, because we're experiencing significant problems, significant pressures at the moment, and we'll have to see how that continues with the change of dynamics in COVID. So number one would be our non-elective services. Second area is the restoration of our planned and elective services. So that's obvious big impacts on the impact of COVID. It's important to us, obviously, at the moment, about how we start to restore lots of our elective activity, lots of which we've continued throughout the pandemic, but all the challenges of social distancing in outpatients, PPE, having more high priority cases than we would do normally, so the impact that has on the efficiency of our services. So lots of logistical and practical challenges about restoring our services, and then the impact that obviously has on long waiting lists and people having to wait a long time, and how people are managed and how they can manage their conditions whilst they're on waiting lists, and actually perhaps some focus as well on people that aren't on waiting lists, and the extent of sort of unmet need. And there's still a big question for us as a trust, as there is across the system, about the undiagnosed health needs, people that may have otherwise been picked up at screening or been to see their GP or other things. So that's still a big unknown for us. Continually we will see continued sort of more late presentation of illness in the hospital that otherwise would have been managed better earlier on. And then also in that planned care, elective care is perhaps people's experiences of, so we've established lots more digital services. People are accessing outpatient services and accessing our services much more digitally, and understanding people's experience of that, and the inequalities dimension to digital access as well. So that's the second one on planned care. The third one is thinking practically about our estate, huge challenges that COVID's brought to how we practically manage our estate across our 5 hospital sites. So COVID, we briefed the board on some of the reconfigurations that we've had to do by moving services to different sites to either make way for COVID patients or to manage patients in a different way, because we've had to have different pathways depending on whether people are COVID positive or COVID negative. So the estate challenges and the reconfigurations as well of sort of restoring our services and bringing services, the longer term home for some of our services. And then obviously within that this is perhaps more longer term, but current as well, is our new hospitals at the LGI and the new pathology laboratory at our St James's site. So we are next week going to be launching some of the new designs for that hospital, and there'll be obviously Scrutiny Board have been involved in the maternity consultation. There'll be more things to do with that huge project over the coming years. So that's estate, thinking practically, and then fourthly and lastly is just some of our strategic considerations. So people have mentioned the integrated care system and the ICS, which is important to us, and how people's voice and how people are represented in those structures, but also just thinking the purpose of those structures is for more integrated care. So making sure there's maintained focus on integration and coordination of care, particularly in and out of the hospital, and as has been mentioned, transitions between care. Also on strategy, there's various important things that were important to us beforehand, but COVID has amplified, if you like. So things about how important it is and the impact we can have as a trust in reducing inequalities, and what the Marmot principles might look to us as a big acute trust, and then our ongoing challenges about that are brought from demographic changes, our workforce pressures, all those things that have been on our minds and in our strategy, but COVID has amplified and made even more important, as if they weren't important beforehand. And then two more things within that wider strategy piece. Perhaps we've not mentioned this yet, but really important for us as a trust is last year we launched our green plan, looking at the impact of the impact of the trust on the green agenda and sustainability, and there's loads of things within there, and also our role as a big employer and spender of public money as an anchor institution as well, perhaps is of relevance. And then finally, it's a COVID knock-on is our lessons learned from COVID, and implementing our new ways of working, and whatever the new normal is from COVID, the way that people access our services, and also the way that we manage our services beyond a pandemic as we go into the endemic stage of COVID. That's a very long list, but they're some of the things that are important to us as the trust. I'm sure there's things I've left off as well.
Thank you very much, Rob. I like it when you had two finally. Excellent. Thanks for the update. Right, have we got any questions for Rob before we go on to Sam? Sam has got a quick update for us on community healthcare and priorities as well. Any questions for Rob in the meantime? Fabulous. Right, okay, we'll move on to Sam now. Over to you, Sam Prince.
Thank you very much. So there's significant overlap with previous contributors, but 4 areas from me. There's effects of COVID, so in terms of backlog, but also, as I said previously, about the surge, the services that we're seeing with additional demand because of pent-up demand and changes in circumstances. And I've also put in that area talking about the community long COVID rehabilitation service that's just newly established in the last year, and where that's going, and a discussion on that would be good. The second area is around system resilience. Are we ready for a further surge of COVID if that comes? Are we ready for winter? Do we know what winter is going to look like this year, and are we prepared? As part of that, there's a national initiative that we need to implement this year, and that's around a 2-hour response for community services. If we look at the suite of data that is collected at the moment, the importance of community services isn't always visible. And I think that the introduction of the 2-hour response target will mean that community services have a bigger profile as other parts of the system. So you may want to understand about that. The third area is, I would say, is of course about the vaccination programme and where we have been successful and where we've got lessons to learn, and thinking about that in terms of what the autumn may bring in terms of a booster programme. And finally, looking after all our staff, because I don't think we can forget the impact that the last year has had on all staff working across health and social care, and what are we doing as good employers to make sure that we're maintaining their health and well-being. Thank you.
Thank you very much, Sam. And yeah, you couldn't say that better in terms of the contributions of all our healthcare workers throughout the pandemic. It's just been priceless. So thank you very much for that. Any questions following that? Right, okay. We have two options for the next agenda. We either have a 5 minutes break, because we finished well before the time. So well done to everyone who's been talking through their priorities to us. You've done very well and in good timing as well. If we can either have a 5 minutes break and come back for performance update from our exec members and the directors, or we go straight into it and finish earlier. What would we like? If you give me a thumbs up, that means you want 5 minutes break. If you don't give me a thumbs up, that means you want us to continue. Right, we're going to continue. Fantastic. Okay, no problem. Next, we have performance update, and the report provides an overview of outcomes and service performance related to the council priorities and services within the remit of this scrutiny board. The report is presented in 3 distinct sections reflective of council accountabilities. These are public health, adult social care, and active lifestyle. While these are commonalities in how these relate to the citizens of Leeds, the appendices are in effect distinct reports, with the covering report offering an introduction. It is therefore proposed that the board considers the 3 distinct reports to help structure the discussions that we're going to have in the next hour. Have we got Peter Story in? Peter, are you here?
I am, yes.
Okay.
Sorry,
That's all right.
I'll turn the video on. Yeah.
All right. Would you like to introduce yourself?
I'm Peter Story. I'm a Head of Intelligence and Improvement working in adult social care and also across children's.
Excellent. Thank you very much. Right. So we're going to actually start with public health, and I would invite either Councillor Arif or Victoria to give us a brief introduction.
Thank you, Chair. Just a couple of opening remarks from me, really. First of all, just some highlights. Good to see that there's been a decline in the number of people smoking, but we do have some more work to do in our more deprived areas where, unfortunately, the numbers are not reduced as much. It's also good to see that there's an increase in people completing the drug dependency treatment, and that's positive. And I'm sure there'll be a further discussion about this, but due to the impact of the pandemic, there has been a slight increase in excess weight, which is, as I say, due to the pandemic, a little bit inevitable, but more conversations to be had. Just sort of those highlights from me. I welcome a discussion from the board, and hopefully we'll get involved in the discussions. Thank you, Chair.
Excellent. Thank you very much, Councillor Arif. I'll now move to Councillor Venner.
Thank you, Chair. I'll just make a few brief points and then Cass will have more detail. Obviously, the pandemic's had a really huge impact on services and on the data that's been collected. Compared to last year, requests for support are down by 18% for 18 to 64-year-olds and 35% for over 65s. But as I mentioned earlier, that there is at the moment like a particular demand in some places, including at the front door. The overall number of long-term service users in social care has been broadly in line with the previous year, with a 3% increase in 18 to 64-year-olds and a 2% reduction for over 65s. The reduction in older people is due to a reduction in those supported in care homes that's been offset by an increase in people supported in the community. So a feature of last year, which was happening pre-pandemic but was accelerated by the pandemic, is less older people being supported in care homes and much increased demand for home care. The pandemic has prevented the gathering of surveys for the adult social care outcome framework metrics. And there've also been changes during the year in terms of demand, patterns of demand, operation of services, trends. All that's obviously being monitored, but it's been an extraordinary year and a very challenging year, and that is reflected in the data. To end on a positive note from me, it is encouraging that both the employment and settled accommodation metrics for people with learning disabilities have continued to improve despite the challenges. Thank you, Chair.
Thank you very much, Councillor Venner. I've seen Victoria put her hands up. Victoria, you can come in now.
Thank you, Chair. I was going to make some introductory comments on the public health content in the report, but I'm happy to wait for Kath to come in if she's got anything to add to Councillor Venner's contribution, if that works better.
Shall I go next thing?
Yes,
I want to sort of tell Scrutiny Board a little bit of what it felt like last year, and then how that's played out in our performance and activity statistics, which Councillor Venner has touched on. So we go back to March of last year. We had lockdown happening. And we saw very dramatically, I would say, in those first 3 months and leaning up into the summer, a really significant drop-off in terms of people presenting to services as new customers, but also people who were in receipt of support, sometimes choosing to no longer have that support. Because the fear and the risk of introducing into their household. There has been a very significant impact on informal carers, and again you'll see that in the data around the number of carers who took a direct payment. We saw carers again just choosing to be 100% of the care for that person. And for their loved one not to access services. So that had both an impact on them and in some of the data we saw around people who were being supported by us. So as we've seen and is reported, we got that drop off in both age groups, but particularly marked for older people. As things picked up, we saw a real change in the pattern of where people chose to receive their support, with a real fear about going into care home care. I think some of that was about the restrictions that were in place for families and friends to be able to visit. So people very much saying, no, if at all possible, I want to stay at home, because at least that way I know that I can have support for my loved ones. So we have seen a marked diminution in the number of people admitted to long-term care to be supported in a care home, an increase in the number of people who require a home care package, but also the intensity of those home care packages has been increasing. So the number of people who now have 40 plus hours has gone up, which when you think, well, the alternative was they would have gone into residential care. I'm not surprised by that intensity. I suppose it remains to be seen in this year whether any of that settles back. But just to give you an idea of the sort of sheer numbers we're talking about, it's not in the report, but the number of excess deaths we've seen compared to 2019, which would be our sort of last ordinary year, was 486 people. Now, not all of that may be attributed to COVID, but that's sort of how we can measure the difference. So that is quite significant when you think about the activity of the Directorate. And that particularly comes through when you look at the figure of the older people's population supported in care homes. When you look at the snapshot we do at the end of March, that had reduced by 15%. What was happening at the hospital made a big difference in terms of flows into the enablement service, which was impacted by staff shortages, with staff having to isolate. We had staff off sick as well. So not only did we not get the volume of referrals, but we didn't have the staff group necessarily always to respond. What I would say is that that has improved a lot. Referral rates are picking up, and we can see that when somebody does have an intervention through skills, the percentage of people who are then able to live independently afterwards has improved, which is really positive. Also, during COVID, CQC changed what they were doing with regard to inspection, and actually for quite a while there were no sort of on-the-ground inspections. They took a risk-based approach, so only decided to inspect those agencies or organisations that were flagged of concern. So unsurprisingly, the number of inspections that resulted in either an inadequate or requires improvement outcome has sort of dragged down our performance figure on this, because we were performing really well at 87% in the city of our registered providers being good or outstanding, and that has now dropped to 83.5%. We are seeing now CQC picking up the pace on in-person inspections, so I'm hoping over this next 12 months that percentage will improve. In terms of referrals for safeguarding, again, in that first 3 months of lockdown, our referrals really dropped, which did worry us, but then come to the summer months, they actually rose, and they rose above the 2019 baseline. What we did see is on screening those referrals, that didn't then convert into an increased volume of safeguarding inquiries. That's where we think there's a prima facie case of concern and we need to do some more investigation. So I think perhaps one of the positives of the community response to COVID is there was a greater awareness and vigilance about people's friends and neighbours' vulnerability. So we were getting referrals, but perhaps the intervention that was needed was just some care and support, not necessarily safeguarding. People tend to have a bit of a loose interpretation of safeguarding, with a little s sometimes, meaning I'm just concerned for this person's welfare. But we nonetheless, we deal with what comes through the front door, and we find the appropriate way to respond. And we have seen our impact in terms of desired outcomes being fully or partially met. Once they've been subject to a safeguarding inquiry, we're still achieving 93.5% as an outcome, which is really positive. And I'll leave it there really, and just take any questions or comments.
Okay. Thank you very much, Kath. Victoria, do you want to come in just after Kath, and then we can take questions at the same time after you're done? You're still muted, Victoria.
Oh, I'm terribly sorry. I couldn't hear clearly. Thank you, Chair. If I may, I'll just add some additional comments to Councillor Arif's introductory comments on the public health content of the paper. First of all, I just wanted to highlight, particularly to new members, about how we put together a report and how it fits with the conversation we had previously about looking at the impact of COVID and keeping track on health outcomes and health inequalities. So I'm really mindful how central this is to the Scrutiny Board's interest. In the report, it highlights that this is the first time we've actually brought this report on public health performance as a combined report. It's one part of the three-dimensional report, and obviously the public health reports are in the appendices 17 and 18, 1A and 1B. I would welcome any comments from Scrutiny Board about whether this is helpful or otherwise, because we're very happy to bring this in a way that is most helpful to you. So happy to take views on that. Just in terms of what it is and how we've brought this. Obviously, this is the standard set of indicators that we've previously brought to Scrutiny Board, and it is a very small selection of high-level indicators for public health outcomes, which are broadly split into the population indicators, which are often more longer term. So life expectancy would come under that. And then more operational indicators of how the public health system is delivering, which are more kind of in real time. So there are both of those covered. And just to highlight that the way in which the report talks about Leeds and deprived Leeds reflects the ambition of the health and wellbeing strategy in improving the health of the poorest the fastest. So in terms of being able to track and measure whether that's what we're achieving. The two measures in there contrast the performance of Leeds as a whole, and then deprived Leeds referring to the 10% most deprived quintile of the population. So just to highlight to people, that's why there's that. As much as we can, we try to describe both. It does often mean that we get a figure that would be different if we took it down to a very, very local level. So, for example, for life expectancy, we're looking at just under a 5-year gap for our male and female life expectancy, which is the gap between Leeds as a whole and that 10% most deprived Leeds. Obviously, if we took that to a more localised, even ward level, we would get a greater difference in life expectancy. So it's just to highlight that even though that doesn't seem as large as is often described, it is the difference between the whole and that most deprived 10%. So again, happy to have that conversation with the board and new members in particular. I'll just highlight a couple of things from the content, and then happy to take questions and comments. In terms of the key message for me to relay to you around the population health indicators, and absolutely in that inquiry around impact of COVID on health inequalities, the life expectancy measures in here are hopefully very helpful, but they are there is a time lag to the data that we receive around life expectancy. It's done on a 3-year rolling average. So I need to point out to the board that the figures that we have to date go up to the end of 2019. So the picture that's described in the report is still just pre-COVID for our life expectancy of both women and men from Leeds and deprived Leeds. And just to highlight to people that one of the things that we always say locally, and people like Michael Marmot say nationally and internationally, is even before pandemic, we could see that particularly female life expectancy in our most deprived neighbourhoods was stalling, and the gap was widening with Leeds as a whole. We know that the evidence suggests that the pandemic will widen that inequality. So I just wanted to highlight to the board that this is very much the baseline of where we start the pandemic, and obviously in future scrutiny of where that figure goes, it will start to give us that longer term impact on that gap in life expectancy. So just to pull that one out. And then the last thing I was going to highlight was just pulling out a couple of things from the operational indicators, which I know Councillor Dawson might want to have further conversation around the health check one. But the report shows the real difference in the impact of the pandemic on the delivery of public health services, and the NHS health check, and the fact that that was really thrown off course, and the service was highly impacted by COVID, because it is delivered mainly through GPs in primary care. We can see that that's actually meant that service has delivered, much less activity than we would expect, and there is a plan to put that back on track. I'm happy to talk through that. That contrasts very much with other public health services, including our drug and alcohol service Forward Leeds, which has adapted incredibly well to the pandemic, and actually in most measures increased its performance and outcomes for people successful drug and alcohol treatment, and we now rank the highest in all of the core cities for our success measures on drug and alcohol treatment. So it was just to really bring out some of those differences, and finally, just that the sexual health services and the RHIV measures, even though these are partly done in primary care, have still performed very well. So it's not primary care generally, it's primary care and some of our public health services. But I'll leave it there, Chair, just to highlight those differences within the report. Thank you.
Thank you very much, Victoria, for that comprehensive introduction, and for yours as well, Kath. Really grateful. I will now open up to members of the board. If you have any comments, questions, I'll start with Karen. Karen, I did see your hands up earlier on before Kath came in, so I'll take you first and then over to Councillor Cunningham and then Dr. Bale.
Thank you, Chair. I just wondered if there was any updates on the safe and well visits, because many different diagnoses are identified during the safe and well that are multi-agency and that are done with many adults throughout the city. And yet I know that they've been on hold and adults have been receiving phone calls, which, how do you identify whether or not somebody's got something like dementia, or whether they're not having enough fluids a day and keeping on board with their health and well-being? And I just wondered if there was any updates on that, because I understand that the housing officers have not been doing door knocks on people under their remit, and many other services have been withdrawn and just phoning. So could you give me an update on that, please?
Okay, thank you, Karen. Who would like to answer that, please?
Sorry, I'm having difficulty hearing you at times. I think maybe you need to move a little closer to the microphone. I think you might have, did you invite me to respond to that?
I did, yeah.
You did, right, okay.
Can you all hear me?
Probably need to go back to the heads of service to get you a detailed response to that, Councillor Renshaw. What I would say in terms of adult social care is that we've never stopped working in social work. We might have adapted the way we've worked, but we still have our rapid response teams working. We're screening the calls, and we have been going out doing in-person visits where on the basis of the knowledge that we have, we think there is a risk to the individual and we need to see them in person. But I'll go back to heads of service and provide a note following this meeting.
Thank you.
Okay, thank you very much, Kath. Can you all hear me clearly now? Fabulous, thank you. Councillor Cunningham, thank you.
Thanks, Chair. My question is different, but I can certainly account for the fact that the services do respond when there are situations that are raised in need, as has been happening in my ward over the last couple of weeks. So thank you to the adult social care team for those responses. So my query is regarding the life expectancy inequalities, is it possible for us to have a ward breakdown of those, please? And also maybe a more detailed focus as we emerge through the pandemic in terms of maybe causes of death. So I'm thinking particularly in terms of mental health and increasing suicides as well. Thank you.
Thank you very much. Victoria, is that possible?
Yes, of course, we can certainly share the ward-based life expectancy. In fact, there's all sorts of different ways of cutting it now, isn't there, Councillor Cunningham? We can do healthy life expectancy overall. But we'll certainly look at that on a ward basis. And happy to either do that as a one-off, or we can include that in our regular updates. I think just on the causes of death as well, I think certainly the suicide data is included in headline terms in the report, Councillor Cunningham, and it's broadly stable. It's gone up within the percentage for that. So there's a slight overall rise. It's not statistically significant. We are doing a lot of work to look underneath that overall number in terms of different groups of people, either by age or sex or part of the city, as part of the work of the ongoing suicide prevention partnership group. So yeah, more than happy to share any of that in any detail if that's helpful.
Thank you, Victoria. That is very helpful, and I think it would be useful for us to keep a track of ward-based at a ward-based level as well, if possible. Thank you.
Thank you very much. Dr. Beale.
Thank you, Chair. If I may, through you, a request to Kath Roth. In the past, she has made available the CQC figures for both care homes and home care on a regular basis, and that has been very useful at Scrutiny because we've been able to monitor changes over a period of time. And as she's mentioned, there had been an improvement in the CQC ratings, which unfortunately, because of COVID maybe, has dropped off. So it would be useful to be able to monitor that the CQC ratings are improving over the next few months, a year or so. And secondly, I just really want to pick up what Victoria's been talking about, that is life expectancy at birth from females. Because as she's pointed out, the inequalities have been increasing. Overall, in both men and women, it's increased, but in the women in the most deprived areas, it's actually gone down. And as she said, it's nothing to do with COVID because the figures only go up to 2019, so they're all pre-COVID. They are a reflection of what Michael Marmot found in his 10-year review published earlier last year. So my question is, no, one comment first. I mean, we are, of course, trying to reduce gender inequalities, but that's by improving the life expectancy of males, not by reducing it in women. It's going in totally the wrong direction in women from the more deprived areas. Has she any idea why that is happening? Thank you, Chair.
Thank you. Victoria.
Would you like me to come back on that, Chair? Thank you, John. Thanks very much. Yeah, I think it is really important for us to distinguish kind of pre-COVID trends and then impact of COVID on top of that. And you're absolutely right that the report that Professor Michael Marmot wrote to try to explain what was happening with life expectancy for the first time in 100 years pre-COVID stalling. It was a shame that that report kind of was published February 2020 and was kind of overtaken by COVID, so it was overlooked to some degree. So I think it's really important that we don't lose sight of those findings, because the report that he produced then was a real analysis of 10 years on from when we first set the national strategy around health inequalities. I'm sure you know all this, but just as a reminder, it was an evaluation of the impact of all our interventions and what had worked and what hadn't, and some of the reasons underneath it. So we're very keen, I'm very keen, and I know partners are very keen to revisit that February 2020 report so we don't lose the learning for Leeds, as well as the impact of COVID. We do both at the same time. And as I'm sure you're aware, the overarching findings of that work that Michael Marmot led to look at why have things got worse over the last 10 years, particularly for deprived women, reflected sort of those wider social and economic determinants more generally. So because the gap in inequalities generally, and economic inequalities and people's kind of like living conditions outside the health and care system, that was seen to be the biggest single factor in health inequality. So I know the board's very aware of this, and it forms the absolute bedrock of our health and wellbeing strategy, that 80% of what influences health and wellbeing is outside the health and care service. But Michael Marmot's work clearly reinforced that, and makes very clear recommendations that if we want to do something about it, we need to get to grips with that 80% of those wider determinants on people's lives. So I think that's the challenge ahead, Dr. Beale.
Thank you very much, Victoria. Dr. Beale, have you got any supplementary questions?
No, just to thank Victoria for her comment and saying there may not be a lot we can do as a scrutiny board on that, but we do need to use our influence both within the City Council generally, because a number of those policies are relevant to other things the City Council does, but also in our discussions with people responsible on a national basis, with industry, with government, and so on, to improve those social determinants of health.
Noted, Dr. Bell. Thank you very much. Jane Dowson now.
Yeah, I must say I found that last question really, really interesting, because health, food, what we eat, and so on, all reflect in our health in the long term, not necessarily how many times you visit your doctor. Albeit, Victoria, I'm now going to come on to my favourite subject, and that is doctors are there to pick up early, and I think part of their remit now is prevention of illness as well, by introducing anti-smoking schemes and so on and so forth. So I do think that starting in some way to try and reintroduce the health checks, face-to-face health checks, I'd love to know how we're going to do that. I mean, I went through a whole year and never saw my doctor. I did it all on my mobile phone, point it here, show me that, and I could do that because I had the relevant equipment. But when you have a digital divide such as we've got in Leeds, some people cannot do that. So totally recognise all the problems and all the issues, but we need to get over that as a city and actually work out how we're going to get people back into a venue like their doctors, whether they see the doctor, the nurse, or whoever, where people can actually have a face-to-face conversation, look at those people in the eye and see if there are any issues. Because often when you go to the doctor, you might go with one thing that's wrong with you, but really you want to talk about something completely different that's worrying you, and you can't do that when you're on a 5-minute digital conversation with your doctor. So totally recognise some GPs, surgeries will want to do it, some won't, but I'd love to know what the direction of travel is. I'd love to know what the plans are being put in place to make sure that everybody in Leeds can get the same service from their GP.
Thank you very much, Councillor Dowson, and I agree with that 100%. So Victoria, I believe that's well noted.
Yes, if I could just briefly come back, Chair, and to thank Councillor Dowson for very helpful comments. And I agree with everything you've said, Councillor Dowson. Just very briefly, we in Leeds, we chose to, we have a mandated function as public health in the council to deliver on NHS health checks. Different local authorities do that in different ways. So not everybody does that through GP practices and primary care. In Leeds, we chose to commission GP practices. So we pay them to do the health checks because we felt it was the best way of delivering a holistic service for our people. What's happened in the pandemic is that because the GPs have actually been told centrally, nationally, to deprioritise local authority public health commission services and to prioritise their COVID response, including vaccination, which is entirely understandable, and we get and work with them through all of those pressures. But when they get national letters from central government to say, you know, don't do the health checks, you know, you won't be supported to prioritise them. Obviously, they need to, they're following that national instruction. So we've worked really hard with them to keep as many going as we can, despite that mandate from central government. We've kept about a third of them going in the city, which is nowhere near where we want, obviously. And we are working now with every single GP practice we commission and the GP Confederation to come up with a plan for not only how they're going to get back to 100% delivery, but how they're going to work through the backlog of people they didn't cover. So we need, in this next period, we need to, you know, they need to deliver more than 100% because it's picking up all of the people that haven't been picked up so far. So we recognise the pressure they're still under, but we are kind of holding them to account to still have full delivery, because we're really concerned that if we don't get that early identification and prevention of, as Rob was saying, in the hospital, things that will cause us more problems down the line, it's in nobody's benefit. So we are, we've got meetings with the local medical committee about negotiating exactly how many they do to work through that backlog. So I hope that's helpful for now.
Thank you very much.
Yes, if I could just come back briefly, I think that was absolutely an excellent explanation of where we are. And I think just as a group, as a board, we would potentially, if it's agreed, like to look at what that plan is going forward. So totally recognise the issues, totally recognise COVID, totally recognise where we are, but where do we go from here to get to where we want to be is, I think, what we'd like to know.
Thank you, Councillor Dowson. I'll call on Councillor Harrington.
Thank you, Chair. Mine's probably a bit left field, and Victoria won't be surprised. I just want to know that the two groups who haven't been mentioned at all in any of the discussions this afternoon are homeless people and prisoners leaving prison and coming back into community services. And so I'm really concerned that because they are both very chaotic groups generally, how are they being picked up on health checks and the other services that they should be linking into? But I'm not absolutely certain that they will be. And I think, again, we'll be storing up problems for the future with hospitalisations and serious illnesses. So it's just seeking some reassurance, really, that those two groups haven't kind of been dropped off the radar. Thank you.
Thank you very much. Victoria, would you like to come back on that, please?
Yes, thank you, Chair. Thank you, Councillor Harrington. So really happy to provide further information. I think that I was very mindful in the list that we generated before that prisons is another interesting one, and the health of prisoners, because as you and I have discussed many times, Councillor Harrington, it is one of those areas that it's a bit like the dental care conversation before, that we used to have responsibility for commissioning healthcare services locally, and it moved in 2013 to NHS England and is now done very remotely by the national body. Our experience through COVID is that actually we can't not be involved with the health of prisoners, and I think pragmatically we've gone in there. We're you know, and we're very involved in doing what needs to be done with the prison population, but actually it continues to be a fragmented and complex area that I would fully support us having a further conversation around, because if we can't properly look at inequality across the city without looking at prisoners and their families and the workforce of prison. So I fully support that, Councillor Harrington. In terms of the homeless population and rough sleepers and also migrants to the city, in Leeds, we do have a service that not everywhere has, in that we commission a company called Bevan Healthcare to work specifically with people in these groups. So happy to bring something back with more detail on that. And through COVID, it's meant that we've been able to be incredibly responsive in terms of support, vaccination, etc. for that homeless population. And we also work very closely with the York Street GP practice, who provide a specialist primary care service for the homeless population and rough sleepers. So I hope that's helpful for now, but happy to provide any further details.
That's fine. Thank you very much.
Thank you very much. Okay. Any other questions? Right, I will now call on Councillor Arif or, well, active lifestyle. Let's go, Councillor Arif.
Again, I'll do
an introduction on
yes.
active lifestyle. Thank you.
Thank you, Chair.
Phil Evans, that's the name. His name just disappeared from my brain.
So in relation to active lifestyles, the figures clearly show that the impact of the pandemic has increased the inactivity levels locally, but also nationally as well. It's absolutely essential that physical activity is at the heart of the recovery process to improve the overall health and people in Leeds. Just a couple of things that I want to highlight, Chair. So in terms of the positive steps that were taken during the pandemic, Active Leeds delivered a physical activity toolkit to deprived areas in Leeds, providing activities for children to do at home, such as live gymnastic sessions in the garden. We also ran outdoor fitness classes, running, cycling activities, as well as targeted outdoor classes. Over 90,000 calls were carried out to members in all programmes, with a focus on contacting actually older age groups to provide exercise advice and support, including ensuring that they had access to the essential equipment. Chair, I also want to acknowledge that it has been a challenging time, with the service being mobilised, closed, remobilised as a result of the restrictions that took place over the last year. A number of centres have worked around limited capacities as well, and logistical constraints. Staff have really shown a significant amount of flexibility during this period. There's been a real team leads approach from the service that has been redeployed across the organisation over the last 12 months, covering roles as diverse as acting as COVID marshals, working at household waste cycling centres, and working to support the vaccination effort. So I think it's really important that we take this opportunity today to really thank our staff in how they've supported sort of the COVID efforts across the city, and I really want to do that today. Thank you, Chair.
Thank you very much, Councillor Arif, and I can only add to that, because I do know, in terms of some sports centres around the city, especially the sports centre where I coach, which is the Leeds City Athletics Club, and I know how difficult it was over the last 1 year really in terms of trying to coach young people with lots of the centres being shut, and we couldn't just make use of our buildings, and then we start for 2 months and then it gets shut down and then we come back after that. And luckily it's been open since the 29th of March, and I can't tell you the excitement on the faces of our young ones just knowing that our sports centres are open. And obviously with the active lifestyle team and what they have done to make that possible, I personally want to say thank you, because that has put a lot of smiles on a lot of children's faces. So I want to say thank you for what you've just said, and just to add to what you've said regarding that. If anybody has got any questions on what Councillor Arif has just said regarding active lifestyle, please feel free to raise your hands. Nobody? Councillor Dowson, had to be her.
Sorry, me again. I just wanted to say a big thank you to Active Leeds, because obviously because I had to be at home for so much, I really enjoyed the online classes that Active Leeds put on. And trust me, you probably see on the screen, I'm not one of the slimmest people in the world. For those of us who are overweight, for people perhaps culturally who don't want to mix with other sexes or whatever when they're doing their exercise, that online class was fantastic. And I really would recommend Clubbercise to anybody.
Fabulous. Thank you very much, Councillor Dowson. Phil Evans, have you got anything to add?
Not really, Chair, but we're grateful for the comments of members, and we'll make sure that the staff generally are informed, that members are appreciative of what's gone on. The only thing I'd probably add, and it's not related to the Q4 and end of year position that's reported here, is just to sort of let members know that we still continue to operate the services under some restrictions. So we do have limited capacities, we do have issues about access and egress and ventilation issues. So just bear with us, I think, in terms of what we're able to continue to deliver until July the 19th. But we are really, really looking forward to that day coming when we can get back to full operation of the service, because we know that people out there are desperate to make maximum use of the facilities that we have.
Thank you very much. Before I go back to Angela, Peter, is there anything you would like to add?
No, just to say thank you. I'd just welcome any feedback on the report. We bring it twice a year, once to inform you at the start of your scrutiny cycle and then with the budget cycle. We cram a lot of information in there without probably having all the detail you want on any one subject. So just welcome any feedback on, is it meeting your needs, and what else could we do?
Thank you very much, Peter. I will now hand over to Angela to go through our work schedule for the year.
Thank you, Chair. So this report presents a draft work schedule for this municipal year, which is Appendix 1 for the board's consideration. Clearly, there have been a number of suggested key areas that the board may wish to explore this year. Should members want to drill down into any of these areas in detail, in the first instance, we could perhaps look at scheduling them as dedicated agenda items, or look at part of regular update reports, which I know Councillor Venner in particular had made that suggestion. Within the report itself, I'd like to draw members' attention to a particular area of work that the former Scrutiny Board had put forward as a suggestion to the successor board, which is to explore how GP services are planning to safely return to a face-to-face appointment service, but obviously reflecting on the earlier discussions that the board's just had, members may wish to broaden this to look at what are considered to be sort of same-day response services, and also plans surrounding the re-engagement of other specialist commission services too. And I know particular reference has already been made to health checks. You'll also note within the report that reference is made to a health service developments working group meeting that was held on the 26th of April this year. That was to consider development proposals linked to the adult inpatient stroke rehabilitation service and community neurological rehabilitation services in Leeds. During that working group meeting, board members have requested that further service-related information, including patient numbers, waiting times, initial findings arising from the ongoing patient engagement that's been undertaken, for that to be made available for this successor board by early June, so that board members can determine appropriate next steps. This additional information has now been circulated to board members, and as such, it's now being proposed by this board that it utilises its planned meeting on the 5th of October to consider the future vision for stroke services in Leeds more generally. And in doing so, the board will also receive at that point an updated position regarding the development of the adult inpatient stroke rehabilitation service and the community neurological rehabilitation service. You'll also note within the work schedule Appendix 1 that it does set out future meeting dates for this board. The next meeting is scheduled to take place on 13th of July at 1:30 p.m. The status of that particular meeting will be confirmed closer to the meeting date itself, but will be made clear on the council's website. However, moving forward, it is intended that all scrutiny board meetings, whether they're remote consultative meetings or formal public meetings held in the Civic Hall and in accordance with legislation, that they will continue to be webcast live for public access. While reference was made earlier to the ongoing work being undertaken by the West Yorkshire Joint Health Review and Scrutiny Committee surrounding forthcoming health and care bill, you'll note within the draft work schedule that it is currently proposed that the scrutiny board also receives an update position on the bill, should it be published by then, during its next meeting in July, and also the ongoing development of the integrated care system in West Yorkshire, as that was also flagged as one of the suggested areas of interest during today's discussion. So reflecting on all the information that's been presented today, members are now being asked to consider if there are any particular areas that they would like to prioritise. And after today's meeting, I'll then work with the chair to look at how best we can reflect those into the board's work schedule for the forthcoming year. We'll bring, in doing so, we'll bring an updated version of the work schedule back to the board's next meeting. Thank you, Chair. Sorry, Chair, you're still on mute.
Sorry about that. Thank you very much, Angela. I've seen Councillor Latty, you've got your hands up.
Thank you, Madam Chairman. Yes, just a question of the work schedule. We've talked about discussing GP services. I would like to flag up that I think that integral to that study, discussion, whatever, that we should really look into this digital access business as a most important part of it. I hope it, going forward, it is a part of rather than the total of. So I do think it's something that we really do need to include within that. Okay.
Thank you, Councillor Latty. Anyone else like to come in? Okay. Have we all said enough then? Councillor Hart.
Aye, just a quick one. I don't know if it falls within the remit of this committee, but obviously around Leeds we have some fantastic kind of third sector voluntary groups that pick up a lot of the supplementary healthcare work, whether it be for mental health or other issues. I don't know if the scrutiny of that or the understanding what network exists across Leeds sits within this group. But my own view is that with the stretch on GP services, the stretch on hospitals and the NHS in general, I personally think there is a bigger role within society for groups that can offer, almost like low level kind of pre-contact mental health support, kind of support groups, but also kind of, other groups that are kind of for activities. So it'd be good to understand the kind of the topography that exists already across Leeds and where there are opportunities to kind of, learn from what is best practice and model that.
Okay, thank you very much. Third sector, Angela, do you want to say something about
Yes, Chair, just to explain, I know in terms of pieces of work that we have undertaken, or this board's undertaken, where we do get the views across the health and social care sector, we do very much try and engage with the third sector as well. So depending on obviously these areas that the board wish to reflect in its work schedule, I'm quite happy to engage and get the voice of the third sector as part of pieces of work that this board does.
Thank you very much. And Councillor, to also add to that, I'm not sure we could have survived as a council without our third sectors over the last 12, 13 months. It's just been unbelievable how helpful, selfless and tireless our third sectors have been, especially, just reaching out to vulnerable people, from caring for vulnerable people, from food, from donations, from mental health, organizations, just name them.
Yeah,
So
absolutely. And it's because, there's so many people and so many groups have stepped into the fray to pick things up. And some of those groups will be looking in the 6 months to 1 year ahead to step back and stop some activities. But others, have discovered a renewed enthusiasm and passion for doing these things, and almost kind of need a little bit of kind of support and culturing to make what flourished out of necessity last year and into this year become a model of what is good.
Definitely. Thank you very much.
Thanks.
Thank you, Harrington.
Yeah, it was just to say that don't forget about the work, Conrad, that the LCPs do, the local care partnerships. Certainly the local care partnership that I sit on is very, very mindful of the third sector organisations. They're actually involved in that LCP. So again, it's possibly looking at a list of, you have a list of the third sector organisations that are dealing with issues, but how they link into the local care partnerships across the city. So some LCPs are further advanced than others in that area, but certainly we are encouraging people from the third sector organisations in our area to actually be part of the LCP process.
Thank you very much, Councillor Harrington. Yes, Victoria.
Yes, it was just a quick comment to support the comments councillors just made around third sector, and I just wanted to add that often, certainly for our public health services across the city, they're very much at the centre of delivery rather than just supplementary to the statutory sector. So, many of our public health sector, we actively choose the third sector as the best providers for what we want to deliver. So just to support your point, but to go even further, to say they are absolutely in the centre and often give us the best reach as trusted organisations into communities. So very supportive to keep third sector at the heart of all of these conversations.
Absolutely. Thank you very much. An old hand on that for you. Councillor Latte, is that an old hand? You're muted. Can't hear you, sorry.
I say it's a very old hand.
It's a very old hand. All right, that's okay. Councillor Venner.
I just wanted to build on the point Victoria just made about the third sector, and particularly when we're looking at the health inequalities agenda. The third sector, I'm from a third sector background, as many of you will know, and the third sector very often has better reach into communities, marginalised communities, because of issues around trust and accessibility. I previously worked for a mental health charity that set up a bone-specific mental health crisis service, and also a deaf service, an LGBT service, and a trans service. And there are really good historical reasons why people from some communities, such as the LGBT community or BAME communities, are mistrusting of statutory services, like the council, like the NHS. And so very often the third sector charities are very rooted in communities and are just more trusted because we don't have the third sector doesn't have the statutory powers that we have. So whether that's, we've got the power to remove children, we've got the power, or the whole health network has the power to remove people's liberty, and we have the power to evict people. And the third sector doesn't have any of those powers, and so doesn't carry that baggage. And obviously there's a lot of historical issues as well around structural oppression, but all of that combined means that third sector services can be just much more accessible and have much better reach into communities. So both with public health and care, they are a really, really important part of the system and do a huge amount of work. You know, just the volume of people that they support is vast, and will often be the only services that people are working with. Thank you.
Excellent. Thank you very much, Councillor Venner. Any other comments or questions? Right, okay. I just want to say a very, very huge thank you to all of you. It's been a long day, since some of you have been here since 1 o'clock, so thank you. What I would like to say now is we have listened to all the various suggestions, all the areas of priorities that you would like us to consider. We will go back, myself and the principal officer will come back to you at our next meeting, you know, with the next work schedule of what we would be looking at throughout 2021 to 2022. But in the meantime, you don't need to wait until July. If you have anything on any area that you would like us to consider, please just send an email through or just pick up the phone and just give me a ring, and we will do our very best to see what we could do to include that onto our agenda. So yes, from all of us on the board, for everyone who's joined us, thank you very much to all our exec members for all your contributions and answering all our questions. To the directors as well, we want to say thank you. We also have Dr. Jenkins, who's actually observing today, I believe. Is that correct? So thank you for joining us. Dr. Jenkins has come all the way from Seacroft. That's really far away. So thank you, Dr. Jenkins. Councillor Jenkins for joining us. And we also have Councillor Renshaw, who's subbing for Councillor Taylor. So thank you very much for joining us. And that's everything from all of us today. Have a lovely evening, you all, and take care. Thank you.
Thank you, Chair.